This video will talk about cardioversion of a patient. Normally you do everything on this list, but to keep things concise, we'll focus on the steps in blue, and we'll also cover frequently asked questions and include a summary. As a word of caution, we're not covering every possible type of equipment on the market. Make sure you understand how your own equipment works and how it may affect your procedure.
As with any procedure, don't forget to wash your hands, introduce yourself to the client, explain the procedure, and receive consent. Start by administering oxygen and obtaining intravenous access. If possible, administer a sedative. The most popular choice is midazolam, commonly titrated to 0.5 milligram increments before beginning the procedure. If using self-adhesive electrodes, now's the time to apply them to the chest. The sternal electrodes go just to the right of the sternum, underneath the clavicle. The apical electrode goes on the left mid-axillary line around the 5th and 6th intercostal space. If using traditional paddles, you need to minimize chest impedance. Apply a liberal amount of liquid electrode gel to each paddle or the chest. You could also place 2 solid gel patches on the chest in the same locations you'd place self-adhesive electrodes. Now ensure the sync option is turned on. Give the defibrillator a few seconds to identify an R wave and then double check that it has done so correctly. Choose the appropriate energy depending on the type of dysrhythmia. More on that in a second. Ensure the sync option is turned on and then push the charge button. Once the defibrillator is charged, loudly instruct other caregivers to move away from the patient. Watch out for those ID lanyards too. Before you administer the shock, a phrase that you can say is, "I'm clear, you're clear, everybody's clear." After other caregivers have confirmed they're clear, do one last check. If using self-adhesive electrodes, push the shock button on the defibrillator. If using traditional paddles, place them against the chest using firm pressure, in the same locations you'd place the self-adhesive electrodes, and push both buttons simultaneously. After a short delay, the electrodes should fire at the peak of the R wave. If cardioversion is unsuccessful, allow the defibrillator to resynchronize before your next attempt. Here are some frequently asked questions about cardioversion. What energy level should I select? The energy level you choose will depend on the defibrillator, the patient, and the dysrhythmia. In atrial fibrillation, use an energy of 120 to 200 joules for a biphasic defibrillator, or an energy of 200 joules for a monophasic defibrillator. In atrial flutter, use an energy of 50 to 100 joules for a biphasic defibrillator, or an energy of 100 joules for a monophasic defibrillator. In ventricular tachycardia with a pulse, use an energy of 100 joules for a biphasic defibrillator or an energy of 200 joules for a monophasic defibrillator. For subsequent shocks, you'll usually want to use the same energy again. However, studies have shown that upping the energy with each subsequent shock might improve success rates. As for children, the energy you choose will depend on their weight. Aim for about 0.5 to 1 joules per kilogram for the first shock, and up that to about 2 joules per kilogram for the second shock. What does the sync button do? In cardioversion, the shock has to be synchronized to the peak of the R wave. The defibrillator does this for you when you turn on the sync option. As a quick summary, administer oxygen and sedatives. Apply electrodes, charge the defibrillator, analyze the rhythm, clear patient and shock, and then repeat the process.